It is a great honor and a pleasure to this night to have one of our from the Egyptian stars in Ireland, Dr. Saad Mahdy. He's a consultant anesthetist and University Hospital Limerick in Ireland. He started his journey in medicine from 1990 when he was graduated from Faculty of Medicine at Alexandria University, and he is appreciating and is always belonging to this university. And then the master degree of anesthesia from the same university from Alexandria, and then he find the way to the Ireland, and then this is the FCARCSI from Royal College of Surgeons in Ireland, diploma in healthcare management, and then the CSSD Anesthesia College of Anesthesia, Royal College of Surgeons of Ireland, and then European diploma of Peri-operative adult transesophageal echocardiogram. So he is a member, active member in these societies: Royal College of Surgeons in Ireland, Intensive Care Society of Ireland, European Society of Intensive Care Medicine. He had the leadership and the management experience, and I like his style of working in team and multidisciplinary team approach. And he has many training, many trainees in all aspects of anesthesia, pain management, pre-operative, peri-operative, and post-operative care of different aspects, including brain, chest, GIT, and others. So we are delighted to have Dr. Saad with us this night. And this is one of his photos 5 years ago in Mahdy hospital. And I like this quotation because Dr. Saad used this quotation in his page on the Facebook. No matter how educated, talented, rich, or cool you believe you are, how you treat people ultimately tells all. Integrity is everything. This means that Dr. Saad is not only knowledgeable, skillful, and have the talents to educate, but he is a very sensible human being. And this is the most important issue, is to have an excellent attitude toward disease, toward patients, toward the colleagues and everything. So the attitude is the most important aspect in any physician. Today we have my pleasure to have Professor Saad Khamis, Professor of Internal Medicine and Nephrology, Menoufia University, to chair this session. Dr. Saad is always supporting, has sincere efforts to enrich the educational activities, and this is one of the photos of his share with me in the hemodialysis course in Mansoura, and the society, and the CME in the Egyptian syndicate. So a lot, everywhere, Professor Saad is helping us. I'm expecting a very exciting session because today Dr. Saad will speak about peri-operative management of patients with renal dysfunction. And we hope that the session will be enlightening, brainstorming, and carries the messages for all of us, for nephrologists, for surgeons, and for anesthetists. Because usually our patients, the anesthesia surgeon don't like to proceed with them because the outcome is not good and they need experience and difficulty in the management. So we are eager to know from Dr. Saad today how the issue is there in Ireland, because we like his experience. I'm going to stop my share to allow Dr. Saad to share his slides. Until he shared his slides, Dr. Saad, do you like to introduce Dr. Saad by one or few words?
Thank you, Dr. Hussein. Thank you, Dr. Saad. Thanks for all colleagues Just one statement. I'm welcoming Professor Saad, and inshallah we shall enjoy his talk. And by the end, it will be a hot discussion, inshallah. Thank you so much.
If you allow me, Dr. Saad, before you start, Dr. Saad will speak in English with only a few slides in the beginning because, as I mentioned in the introduction, his heart is in Alexandria, and although he's not nephrologist, but he is appreciating the efforts of the professors in Alexandria University. And this year we lost one of the pillar of nephrology in Egypt, Professor Amr Abeid. So Dr. Saad Mahdy will start his presentation in Arabic part as a condolences for Professor Amr Abeid. Dr. Saad, the mic is to you.
First of all, thank you very much, Professor Hussein. Thank you very much, Professor Saeed, for this overwhelming invitation. I'm so proud to be one of your graduates from Alexandria to be speaking to this prestigious society of nephrology and renal transplant, the Egyptian Society. And before all of those professors and colleagues from nephrology, surgery, and anesthesiology. Once again, and thank you much for selecting me to speak to this event tonight. Basically, I'm very sad for losing, as you mentioned, Prof. Hussein, one of the eminent nephrologists in Alexandria, Professor Amr Abeid. He was a professor of nephrology from Alexandria University. بداية استأذنا زوجته وعشان نتكلم عنه. يعني مهما اتكلمنا عنه مش هنقدر نوفيه القدر الكافي، ولكن يعني أنا كان ليا منظور إن إحنا لابد نكرم نفسنا قبل أن يكرمنا الآخرون. الدكتور عمرو عبيد كان له أفضال كثيرة جدا على كل من درس له وعلى كل من قابله في حياته، سواء علميا أو اجتماعيا. هو طبعا كلنا عارفين الله يرحمه كان خريج كلية الطب دفعة 1978 وحصل على الدكتوراه في النفرولوجي سنة 1988. بصراحة كان رول موديل مع كل زمايله وكل تلامذته وكل أساتذته. الله يرحمه يعني ختم حياته العلمية والعملية، كان أستاذ كبير، موديل أوف نفرولوجي إن ألكسندريا، بل يمكن ايجيبت كلها. كان دايما لاخر ايام حياته كان حريص جدا على الاجتماع العلمي الاسبوعي بتاع قسم الكلى. وطبعا في ناس محظوظه كتير ان هو اشرف على رسائلهم في الدكتوراه والماجستير ونهلوا من علمه وحكمته. الدكتور عمرو عبيد الله يرحمه كان لاخر ايام حياته كان كشفه في العياده اقل بكتير جدا جدا من اصغر طبيب كان بيدرس له. الجانب الانساني عرفنا انه كان بيكفل اسر اجتماعيا ولم احد يعرف عنه حتى الا بعد وفاته. إن شاء الله زوجته الكريمة سوف تتبرع بالمكتبة العلمية الخاصة به لوحدة الكلى في اسكندرية. وبالنيابة عنكم وعن نفسي أنا بشكر الأستاذ الدكتور عصام الكردي رئيس جامعة اسكندرية لأنه كرم زوجته بعد وفاته. الحمد لله رب العالمين. شيء بسيط ولكن برضه له معنى معنوي وأدبي كتير جدا في حياة إنسان. في الواقع إحنا يعني هو ثناء وليس رثاء، فنحن نرث الذين رحلوا ولكنهم عند ربهم أحياء يرزقون. هو حي بعلمه وتضحياته وتفانيه وتحمله في المرض. تألمنا كثيرا لرحيله ولكن لا اعتراض على أمر الله سبحانه وتعالى. هو حي في قلوب مرضاه قبل أسرته وتلاميذه وزملائه. هو الأب والأخ والزوج والأستاذ والصديق، أستاذنا الكبير المرحوم الدكتور عمرو عبيد. أنا اخترت اسم الدكتور عمرو عبيد بالنيابة عن كل الأطباء اللي رحلوا في مرض الكورونا، ومنهم الناس الكبيرة دي زي الدكتور عصمت والدكتور ياسر والدكتور أحمد نضير والدكتور أحمد ماضي. كلنا تألمنا ليهم ولكن برضو لا يفوتني ان اوجه الشكر لكل زمايلنا الان هم الحمد لله رب العالمين قايمين بقافله من جامعه اسكندريه للمناطق النائيه زي براني والسلوم وسيوه، علشان تحت اسم قافله الواجب الوطني وتحت شعار كل الاطباء الذين رحلوا بسبب الكورونا. ودي صوره جاتني يعني الحمد لله رب العالمين، لان انا على تواصل دايما مع كل زملائنا من جامعه اسكندريه، والصوره ديت حصريا للايفنت بتاعت النهارده فيها كل الزملاء، وانا بشكرهم بالنيابه عنكم وبالنيابه عن نفسي. ندخل على الجانب المحاضره.
قبل ما حضرتك تبدا يا دكتور سعد، يعني
اتفضل.
انا بشكر حضرتك على هذه اللمسه الانسانيه العاليه جدا جدا جدا، وقيمه الكلام انه حضرتك دكتور تخدير، ما انتش دكتور كلى ولا بطنه في اسكندريه، وتحمل هذه المشاعر بين جنباتك، فده رقي ومشاعر وإنسانية مفرطة. طبعا هو أستاذنا جميعا وكلنا يعني عرفناه يعني من سنين طويلة جدا، إنسان ومعلم وأستاذ، ربنا يرحمه وتقبله هو ومن رحل، ويعني ويرزقنا كلنا الصبر، مش أسرته بس، إحنا كلنا، لأن احنا طبعا كلنا يعني بنتألم لفقدان الأساتذة العظماء، لكن هي دي سنة الحياة. وبشكرك تاني وثالث ورابع، وننتقل للجزء العلمي. شكرا جزيلا.
انا بشكر حضرتك لاتاحه الفرصه ليا ان انا اتكلم عن استاذنا الكبير الله يرحمه. Once again, I'm so proud to be here between you today talking about this selective topic, which is a peri-operative management of a patient with renal or chronic renal dysfunction. What do you expect me to talk about tonight? What the anesthesiologist need to know about end-stage renal dysfunction? How the anesthesiologist assess his patient pre-operatively? Because I have been working when I started my job in 2010 in Limerick University Hospital as a consultant, and I led the pre-operative assessment clinic for at least 6 years, and I have a lot of addition to that job. So what the anesthetist expect from his colleague nephrologist, and we need to know the renal risk assessment. We need to see the surgical risk assessment and to see the investigation required, and perioperative optimization and intraoperative consideration will lead to us that time, and the post-operative consideration, and we may have some conclusion, take-home message. First of all, we would like to know what kind of patient we meet as anesthetist from your point. First scenario, we have a regular patient. We see that every now and then in the operating room. Our colleague transferred that patient to us, 75 years old, male, end-stage renal disease, and he's in regular hemodialysis via a central catheter, and at least 3 times weekly, and he is scheduled for AV fistula. That's very simple case. We just take 10 minutes, 15 minutes to do the fistula. No, his patient has myocardial ischemia on Alicus, which is antiplatelet, and his high blood pressure on calcium channel blocker. His diabetic and glucophage 850 twice daily, and otherwise he feels that he's all right. The second case, I looked after that patient. He is 48 years old, male. He was HIV positive, and end-stage renal disease, required hemodialysis. His background is malignant hypertension resistant to all medical treatment. He was scheduled for bilateral nephrectomy because that was the only treatment for renal hypertension. Who referred this patient to us? Our colleague nephrologist. And the third case is a 73 years old male. We noted that all male patients, there is some discrimination to the male, scheduled for elective right hemicolectomy. That's completely different now. Ischemic heart disease, he had 2 stents 5 months ago. His creatinine is 210 micromole. His urea is 14. The patient is diabetic and on glucophage, and he requires some insulin as well to control his blood sugar. He has peripheral vascular disease. He's on Plavix, 75 milligram once daily, and is on aspirin as well. He's had echo. his ejection fraction 45%, otherwise he feels it's all right, mild lower limb edema, calcium channel blocker, beta blocker as well for this patient. So renal dysfunction, it is not only through the kidney, it is a broad spectrum disease and has consequences for surgical, anesthetic, and everywhere of the body. And we should realize that peri-operative management, peri-operative assessment, optimization for those patients is mandatory if you are looking for intraoperative and post-operative best outcome, and avoid any complication not required. What we should know about our patient, why it is important, and we need to classify and the pathophysiology of the renal dysfunction. And we need to know the extent of the cardiovascular involvement and dysfunction. And we touch about the volume status of those patients, and if there is any anemia, if there is any electrolyte imbalance, acid-base disorder, and metabolic disorder, pharmacokinetic, pharmacodynamic of the drugs alteration, other issues like heparin, anticoagulation, all of those issues come to our mind. And if there is any intraoperative and post-operative challenge. So why is it important? Is it important to study the chronic function, the chronic kidney dysfunction? I believe it is, because the number has increased exponentially in the last 20 years. In USA alone, it has 1,700 patients per million with end-stage renal disease. Just extreme cases, about 0.5 to 1% of those patients. The issue now, we have a very good nephrologist, a very good training system, and the technology has improved. We have now very good hemodialysis machine, which result in a very good quality of life, and the more patient is staying alive, it's challenging us as anesthetists and surgeons, because they live more, they have more complication and more requirement for anesthesia. Patients with end-stage renal disease have higher risk for cardiovascular complication and coexisting disease. Mortality is 10-fold higher in end-stage renal disease more than non-end-stage renal disease. And still, it is important to know about this section of patients. In epidemiology, the prevalence of end-stage or chronic kidney dysfunction is about 11.7 to 15.1%. The diabetes, which is the most common one, is just only 8.5%. So the chronic kidney disease is much more than diabetes. And the prognosis, yes, it is modified by, if you have money, you can live longer, you can have, but just remember, you can have more complication. Dialysis can facilitate your life, but maybe if you live more as well, it is not as straightforward. If you have dialysis, it is liable for more complication and comorbidities like cerebral vascular stroke, ischemic heart disease, endocarditis, and bowel ischemia, bleeding disorder, amputation, bone marrow problem, general surgery intervention. The prognosis, the bottom line, the prognosis is poor. And in some studies, they found that if the patient is on dialysis, the mortality for after 5 years is around up to 60%. The primary cause of this in those patients mainly is cardiovascular complication. The impact of the end-stage renal disease and peri-operative outcome, patients with end-stage renal disease undergoing vascular have higher mortality in 30 days. Patient, usually older patient, the older, the more complication. And the similar result had been reported in end-stage renal disease. Patient had colonic surgery for diverticulitis. Certainly, sepsis and renal impairment usually result in higher mortality. And in some meta-analysis, people did research in more than 3,000 patients had coronary artery bypass grafting. The mortality is maybe 5.4%, which is the normal patient 1.8%. So at least 3 times higher than normal patient. And in the same for general surgery, no, just for colonic surgery is even higher. For colonic surgery for diverticulitis, nearly 1,000 patients, they found that 25% is the mortality in end-stage renal disease, while it is 2.56 in normal patients. So by definition, CKD, chronic kidney disease, according to the KDIGO, which is very well known to our colleague of nephrology, it is kidney disease improving global outcome. It is defined as kidney transplantation is considered as a chronic kidney disease. Even they are passing good urine, whatever, but they are still considered as chronic kidney disease. And the patient with glomerular filtration rate, which is this figure is very well known, alarming those patients, less than 60 ml per minute per square, 1.73 square meter, more than 3 months in the presence of additional marker like albumin excretion more than 30 gram, albumin creatinine ratio more than 30 milligram per gram, urine sediment abnormalities, or there is any electrolyte or the other metabolic abnormality due to tubular disorder, contributing to definition of chronic kidney disease. So even once again, renal transplant patients are still considered as chronic kidney disease. And the last one, which is the grade 5, they require a long life dialysis or require transplantation. So according to the glomerular filtration rate, there is 5 stages. The worst stage is grade 5, which contribute to less than 15% of the kidney function. The etiology of the chronic kidney disease, just to know a little bit about the diabetic and the hypertensive, they are the most common factor for causing chronic kidney disease. And the other factors like glomerular diseases, interstitial diseases, vascular kidney diseases, and inherited kidney disease, they are a common factor for chronic kidney disease. If you hear all of that, you need to sit in San Stephen Green in the winter and take a breath and come back to think about those patients and think about the pathophysiology for these patients. This slide, I borrowed it from different presentation, and I like it because this slide is just a topic itself. So you need to go a little bit around this slide and to understand the pathophysiology of the chronic kidney disease. To understand the pathophysiology, you have to know the function first of the kidney. So mainly sodium and water retention, excretion or retention or balance. I like the balance, potassium balance, elimination of nitrogen waste, erythropoietin production, acid-base balance, and activation of vitamin D and phosphate elimination. We'll go through all of them again in a little bit more, but just here, if you have a sodium and water retention, it is increased vascular volume and heart failure and lead to edema. Potassium, mainly hyperkalemia, and we are afraid of hyperkalemia intraoperatively. Elimination of nitrogen waste, which lead to retention, lead to uremia, coagulopathy, bleeding, and impaired immune function, skin disorder, gastrointestinal manifestation, neurological manifestation. Might be all of the previous are not important, but this one might be the most important for some people. Erythropoietin production lead to anemia, and acid-base balance lead to acidosis and other metabolic disorder. So in brief, retention of water, anemia, urea intoxication, hyperkalemia, acidosis, and osteomalacia. Just to let you know about the renal blood flow, the kidney receives 20% of the cardiac output. Glomerular filtration rate is the total volume of filtered formed per minute by the kidney. Glomerular filtration rate is held basically by 3 mechanisms: autoregulation, renin-angiotensin system, and the neural control. And that autoregulation now, the kidney is able to control the blood pressure if it's systolic between 80 to 180 millimeter mercury. Blood pressure outside that is not able, just only due to diameter and the pressure. And that is very conclusive diagram. I got it from the internet as well. And just is a RAS system. RAS system, if you understand it, is very, very comprehensive. Just a glomerular apparatus in the kidney, just this apparatus sensing macula densa, sensing a special sense for water load and sodium load, releasing renin, and the renin acting on angiotensinogen, cleaving it to angiotensin 1. Angiotensin 1 go to the lung, releasing angiotensin 2 by angiotensin converting enzyme. Angiotensin 2 is an exclusive hormone for increasing sympathetic activity, increasing tubular absorption of sodium, releasing potassium, and acting on the adrenal cortex, releasing aldosterone, which is other hormone to improve the tubular mineral corticoid. And arterial vasoconstriction is one of the job of the angiotensin 2. And again, angiotensin 2 acting on the posterior pituitary, releasing antidiuretic hormone and improving water reabsorption. Again, we should know about the cardiovascular involvement in the patient once we hear that patient is uremic or renal failure. Contributing factor for cardiovascular effect, like accelerating atherosclerosis, low-grade inflammation, dyslipidemia, especially LDL, RAS disruption, and oxygen-free radical, all of these leading to cardiovascular involvement. And the loss of arterial blood pressure autoregulation and lead to blood pressure flow directly proportional to the mean arterial blood pressure. Because the heart is between the two lungs, anything affecting the heart is visually affecting the lung. So if we had fluid retention, we have shortness of breath. We have CCS, we have shortness of breath. We have hypertension, sodium and water retention, pericarditis, arrhythmia, electrolyte imbalance, conduction defect, vascular calcification. All of this result in cardiovascular disturbance. And eventually, if you have acidosis, you have hyperventilation. Hyperventilation also contributing factor like interstitial edema, alveolar edema, and the pleural effusion. So chronic kidney disease is a systemic factor, a systemic disease. And once you have cardiovascular effect, lead to cardiovascular effect and complication, and you start the vicious circle. The risk of end-stage renal disease is 20 times higher in high blood pressure group than normal. So if you have a high blood pressure, you can develop end-stage renal disease, and as well you can develop cardiac complication from the end-stage renal disease and lead to vicious circle. So once again, you can develop congestive heart failure. Your patient can develop, starting with diastolic heart failure with preserved ejection fraction. And this only noticed by, unless you it won't be noticed unless you send your patient for echocardiography, especially somebody who is specific about tissue Doppler. And all manifested by general manifestation, general complaint like fatigue, dyspnea, palpitation, hypotension, progressive pulmonary edema. Eventually, this patient will lead to or will develop a systolic or congestive heart failure. We need to know about the volume of the patient, like the basosurgery, how it's happened, basically impaired salt and water excretion lead to volume overload. And the patient, if he has AV fistula, it might lead to occlusion, mesenteric vascular infarction, mesenteric vascular occlusion, and lead to increased morbidity and mortality. Still, is it important topic to talk about? Yes, it is, certainly. And the volume, again, usually your patient, if you dialyze him more and the negative balance, you have dehydration due to dialysis, which result in dizziness and tinnitus and hypotension due to disequilibrium syndrome. High hemodialysis would be associated with fluid shift and dehydration. Usually the fluid either overloaded or dehydration. And more or less for me, both are critical for the patient. Increase body mass, decrease the body mass for dehydration. They are hypertensive in overload, they are hypotensive in dehydration. They have edema, they have palpitation, they have dyspnea, breathless, and headache in overload. They can have syncope and vomiting, nausea, disequilibrium syndrome in dehydration. In anemia, is the fourth item we can speak about is anemia, because it is due to erythropoietin production impairment, and the symptoms again is general symptoms like dyspnea, dizziness, palpitation, potential myopathy, and in some studies they found that erythropoietin stimulating factor improves the hemoglobin and decrease the transfusion and improve the quality of life. But it's just to consider that it is very expensive and it is not without side effect. If you decide about blood transfusion, they should be restricted for special consideration, because those patients, if you think about renal transplant, because they have to be white cell depleted and irradiated to the CMV. I had one patient before, and he came for heart surgery, and we give him blood without being CMV irradiated. That patient was candidate for transplant, and it was some investigation how it come you give the patient blood without being CMV irradiated. End-stage renal disease, they have coagulopathy and they have the bleeding disorder. In uremia, they affect platelet function and the platelet endothelial adhesion. The last one, not the last one, one of the metabolic disorder is acid-base homeostasis and acid-base balance. We know all by heart the buffering system in the body is the lung, which is acting in the intracellular and extracellular mechanism acting in seconds, lung acting in minutes, and the kidney acting in hours and maybe days. And that kidney need to adapt to excrete H ion and preserve the bicarbonate. Metabolic disorder, which usually happen in chronic kidney disorder, usually we mention the glomerular filtration rate between 50 and 60 ml per minute per square 1.73 square meter is alarming sign, is alarming test for those kidneys to retention of H ion, and make the insulin resistant and the thyroid dysfunction. And patient require as a high cortisol level, reduced insulin-like growth factor 1, and the normal anion gap as a metabolic acidosis. Those patients are usually hyperkalemia, and we find some calcium, phosphate, and bone metabolism disorder. Vitamin D and calcium, which is result in laryngospasm, QT, interval prolongation, and sometimes you find them arrhythmia. Usually hyperparathyroidism, hypercalcemia, and hyperphosphatemia, and osteoporosis and calcium deposition. If you have all of that, you need to sit beside malahide castle, take a deep breath, and think what you're going to do for this region. This malahide castle, one of the main interesting tourist point in Dublin, which is extremely nice, and it is very nice to visit and take a tour inside. We saw the patient, we know the patient, and we need to know about peri-operative consideration. Usually, if you have a patient like that, we need to make a multidisciplinary team between the anesthetist, the surgeon, nephrologist, and maybe the cardiologist. And the aim of that is to optimize the medical condition of this patient and address any potential reversible risk. And we need to know the renal risk assessment and intervention, cardiac risk assessment, and surgical risk factor, dialysis and renal transplant patient, we need to talk about them, and anemia and other factors. And we need to know, from our colleague from the other side, what is the medical history of this patient and what is the comorbidities, because this patient is under your care for years and years and years, and he develops some acute abdomen, develops some cardiac problem, needs a bypass or need even a hip fixation. So we need to know what is the comorbidities for this patient, and decision for end-stage renal disease related surgery like fistula, nephrectomy, parathyroidectomy, and what is the future management for this patient? What is the goal after doing all of that? And what is your plan for rehabilitation for this patient? And we need to know early and optimum preoperative optimization of those patients leads to very good post-operative recovery and avoid any undue complication. Renal risk assessment, we need to know the proper assessment of the patient and avoid further deterioration of the kidney function. And it's very important to do no harm to those patients, especially the patient who I mentioned. I will talk about that later on, who I mentioned that he has chronic kidney disease, but he never required dialysis. As anesthetist, do whatever you can do not to let him to require any dialysis after surgery. Identify the risk factor for those patients, optimize the anesthetic technique and correction any electrolyte imbalance, and use the proper pain management post-operatively. That's very simply like that, but not simple, because those patients have cardiovascular risk factor, and the prevalence of cardiovascular disease and increased perioperative morbidity and mortality. We are guided by the American College of Cardiologists and the American Heart Association guidelines intraoperatively or perioperative assessment. Because if you have a chronic kidney disease and the cardiac issue, those patients have double mortality and morbidity. So we should identify the surgical risk factor for non-cardiac surgery, major risk factor, intermediate risk factor, and minor risk factor. And by the American College of the Cardiologists and the American Heart Association, they identified those factors from the cardiac point of view. If the patient has a perioperative cardiac issue, he has a chance to develop 1% pericardiac morbidity and mortality if they have this kind of surgery, which is the minor surgery. If you go a little bit higher risk surgery like intraperitoneal splenectomy and hernia cholecystectomy, they have risk to develop 1.5% perioperative cardiac events. And if the patient has any of those high risk surgery, he has to develop, or he might develop a cardiac event more than 5%. Why I mention here like that? Because the cardiac morbidity and renal morbidity, they are married to each other. If you have a patient with cardiac morbidity and renal morbidity, the risk is double. So the component of the cardiac risk factor, if you talk about that, you will not ignore the renal disorder, because the renal insufficiency, if you have a patient with a renal insufficiency and his creatinine is more than 177 micromole per liter, he has a higher chance to develop perioperative myocardial and cardiac event. In more than 34,000 patients, a big study, prospective study done by Dr. Lee, and he's a big man in the cardiac researcher in 29 hospital, multi-center, multinational study, and they found that revised cardiac index predictor, and they found that the history of myocardial ischemia, history of congestive heart failure, even controlled heart failure is still causing a risk factor. Likewise, if the patient has renal transplant, even well-being is still considered as chronic kidney disease. So they have, if the patient has history of cerebrovascular diseases, history of diabetes, and the perioperative creatinine. Again, if those patients has high creatinine, they still have high myocardial events. Again, clinical risk factor, which is revised several times, and the ischemic heart diseases, heart failure, stroke, transient attack, and even here, the kidney and the chronic kidney disease causing a big factor, contributing factor to perioperative cardiac event. Huge list of cardiac investigation we may think about. And this patient, if he's ischemic heart disease, you refer him to stent or revascularization. Coronary stent usually is much easier, but the 30 days mortality, as regard the 30 days mortality, but however, 5 years better outcome with revascularization. And even if you think about AAA for EVAR, yes, it's good, but you know that you inject a lot of contrast perioperatively. So people with hypertension and congestive heart failure, you have a target blood pressure, and which is normal blood pressure. I wish my blood pressure like this blood pressure 130/80, but in end-stage renal failure, they are always anuric, preserved urine output. You need to know, do they have urine output like that patient who will never require dialysis, but his kidney function is impaired. Does he respond to low diuretic or not? What are you going to use for those patients? You think about inodilator to reduce the preload, or the vitamin to improve the cardiac function, or GTN, triglyceride nitrate, to improve the coronary circulation. Arrhythmia should be controlled, especially if the atrial fibrillation is a lot of research done, and they found that rate control is even better than the rhythm control. Does the patient have diastolic heart failure? Because those patients with diastolic heart failure with any stress, they can result in systolic heart failure or congestive heart failure. So once again, we need to know the renal risk assessment, cardiac assessment, surgical risk assessment, and dialysis if there is any. And the surgical risk factor, what type of surgery this patient is going to have. To have a below knee amputation, will have spinal and anesthesia, or going to have laparotomy, or going to have the aortic aneurysm repair. Is the surgery is emergency or elective? Because basically, emergency surgery is much more dangerous than elective surgery, especially with chronic kidney disease. They are associated with higher mortality. So chronic kidney disease, for cardiac patient, cardiac surgery is estimated mortality between 10 to 20% increased, even more with the risk factor like diabetes. Sorry, just some water. So again, perioperative assessment, it is multidisciplinary team, and we need to know about all of those risks. Again, if the patient is dialysis, what type of dialysis? Is it hemodialysis or peritoneal dialysis? How often the dialysis? All of this information are important for me as anesthetist, and we need to know when the last dialysis, when the last session, what is the serum, urea, creatinine, and potassium. It's very important to know about the serum potassium. It will affect my perioperative plan. And the perioperative dialysis might result in corrective electrolyte imbalance, acid-base balance, and how the adequate of the dialysis. And we need to remove the urea, the uremic toxins, and when he's going to have, when he's due for dialysis post-operatively. And is it dialysis, is it pre-operatively, is it heparin free or with heparin? We need to know the half-life here, because it will affect the perioperative bleeding and transfusion. Okay, and we need to know the post-operative due for dialysis. Patient requires peritoneal dialysis, and going to have abdominal surgery, they should shift to a catheter dialysis or fistula dialysis if they are going to have abdominal surgery, because it will affect the wound healing. Transplant patient, we think about them because they have loads of drugs. Sometimes we need to consult the transplant team, or at least we need to consult our colleague from the nephrology department to know what drugs are going to continue and what drugs going to stop. And sometimes we need to do the level of drugs. And again, last one is anemia. So anemia and other factors: anemia, hyperkalemia, hypercalcemia, bleeding risk, glucose, and the gastrointestinal disorder. So we'll talk about anemia. We mentioned before erythropoietin stimulating agent has cut the rate of transfusion by half in those patients. And our target hemoglobin, I wish the patient hemoglobin is around 11.2, but the set point is around 10. So erythropoietin stimulating factor is not without side effect. The target now is 11 gram per deciliter for the hemoglobin. The second factor with the erythropoietin stimulating factor is newly coming as iron infusion. Iron could be given even one day before surgery. It will improve the hemoglobin and it will cut the transfusion. Why those patients are at bleeding risk? Basically, because they just finished the dialysis with heparin, and it will reduce dialysis itself, it will reduce the platelet function. If you give them, to overcome that, you should give them dialysis, heparin-free dialysis. Most of those patients are on antiplatelets like Xalerto, Blavix, because they have peripheral vascular disease. So you need to know when they are off those patients and when they have to be off. Are they going to be bridged or not bridged? And are they on heparin infusion or low molecular weight heparin? Because we know the low molecular weight heparin, the half-life is increased in renal failure. Sometimes if the patient has bleeding, there is worthwhile to vasopressin, and they may reduce the bleeding in end-stage renal disease. Those patients with anemia, they survive very well with hemoglobin, even 7, 8, 9. Why like that? Because Allah gave us a gift, because they can move the oxygen distribution curve to the right. And we know that if there is any increase in D3, DBG, uremia, dialysis, those are the reference I quoted, but it's not here. And move the oxygen distribution curve to the right, and they lead to improve the oxygen delivery at the tissue level. Efficacy and the safety of intravenous iron study, it has been studied, therapy, it has been studied as alternative and adjuvant to allogeneic blood transfusion. And this intravenous iron administration with Rehobo to immunosurgical, medical surgical patient surgery seemed to be safe, as well as severe side effects were observed. And they found that it was a randomized controlled trial on the safety and the efficacy and the cost effective on intravenous iron treating anemia in clinical setting. And they found that they classified the patient into 4 groups, and it was about nearly 800 patients, and they found that the dialysis required in the anemic patient, sepsis is higher in anemic patient, and the mortality is higher in the anemic patient, of course. And the preset hemoglobin was 11, was the best result of them. So if you decided to transfuse your patient, you should think about several times about the side effect of transfusion. Between the infection, hepatitis, all of these are complications of blood transfusion, and we always teach our student and junior doctor about complication of blood transfusion. The other factor, which is hyperkalemia and hypercalcemia. Hyperkalemia is an indication for dialysis itself, and how to diagnose, usually diagnosed simply with blood gas, send the sample to the lab, or wait for the ECG to develop ECG abnormalities for hyperkalemia. How to treat chronic hyperkalemia and acute hyperkalemia. You should know all of that. And why calcium is indicated? Because it increases the cardiac muscle threshold to arrhythmia, and it is membrane stabilizer. And usually in acute stage intraoperatively, we use sodium bicarbonate, 2 millimole per minute, to over 1 hour to improve the serum potassium, because it improves the intracellular uptake of serum potassium. The other factor like insulin, salbutamol, they have synergistic effect for hyperkalemia to improve the cellular uptake of potassium. And in emergency stage, you can consult your colleague in the nephrology department, and this patient will need urgent hemodialysis. And why serum potassium is very important for us as anesthetist, because there is some contraindicated drugs to give while the patient is hyperkalemic, like, for example, the dexamethasone is absolutely contraindicated if the serum potassium is more than 5.5. So the other factor, which is blood glucose and gastrointestinal disorder, blood glucose, usually we are guided by glycosylated hemoglobin. It should be less than 7.1. More than that, it impairs the microvascular circulation, and it accelerates the microvascular complication. Delays the progress in renal disease. You have to get the glycosylated hemoglobin less than 7.1. And sometimes this figure here, but the burned out diabetes, because they may have adverse effect despite the glycosylated hemoglobin less than 6%. Other factor may have adverse effect like malnutrition, protein, energy wasting, reduced clearance of exogenous oxygen, and accumulated urine toxin. So around 2001, there is a great researcher from Germany, I think, or Dutch, great Vandenberg. And when we go to the exam and we don't mention or we don't know great Vandenberg will fail in the exam. It was very tight blood sugar control, and which failed to be popularity in this situation, because the complication of the hypoglycemia is much more than the complication of hyperglycemia. So the setup of the 10 millimole per deciliter is agreeable to be the target, or to be at least the highest number of the blood sugar in intraoperative or perioperative period. In gastrointestinal disorder, for those patients chronic kidney disease, we have to realize they have gastroparesis due to uremia. If the patient is uremic and diabetic, there is a higher risk for aspiration due to autonomic neuropathy, and there is a bleeding as well, bleeding due to platelet dysfunction, and sometimes those patients has heparin-induced coagulopathy like HIT. So those patients are contraindicated to have transfusion echo study. Now, you have assessed your patient, you stratified the risk, and your patient has loads of fluid. And you think now about the investigation you are going to do for this patient. Basically, basic investigation like urine analysis, serum creatinine, urea nitrogen, glomerular filtration rate if you have a big department. And this will detect any underlying renal deficiency and the potential developing another acute on top of chronic renal failure. Glomerular filtration rate will help you, and your colleague nephrologist will help you to adjust some doses intraoperatively or post-operatively, like antibiotics and other drugs, and avoid any accumulation of those drugs. And it will help you to quantify the perioperative risk. Perioperative assessment of those patients carries the highest risk and cardiac morbidity and mortality. Basically, we take a history, physical examination, and we do the investigation, and the assessment includes objective and subjective as well. To minimize those risks, we have to have those non-urgent cases should be deferred till to be optimized. surgery could enhance recovery from renal diseases like fistula or whatever. It could be, or nephrectomy, it could improve the renal symptoms. And good communication between multiple stimuli team is the best way to do it. And avoid non-invasive surgery. It could be replaced by minimally invasive surgery. It can result in better outcome, like EVAR or endovascular or laparoscopic or robotic surgery at the moment. And the best way to avoid nephrotic drugs and like contrast. So pre-operative assessment for those patients, and we need to know again the duration of disease. We need to know the fluid status of those patients, like euvolemic, overloaded, or dry weight. And does this patient require dialysis or not? Is this patient does he have diuretic response or not? If there is any cardiovascular involvement, and if you have those patients, think about everything is the consent. You need to explain to the patient what you're going to have. Lines, even lines, putting cannula, putting arterial line, putting central line, you have to talk to the patient about all of that. And you have to control your blood pressure. You have to optimize the heart failure. You have to think about electrolyte, coagulopathy, transfusion, erythropoietin stimulating factors. If the patient has heparin-free dialysis, any antiplatelet, all of this, you are here, the anesthetist, and all of this coming to your mind. If the patient had anemia, if the patient had iron, transfusion, maybe he has different things like this equilibrium syndrome, which is maybe very important for you to know. If you have all of that, come here and relax in County Kerry. And this is a very nice place. It's called Ring of Kerry Drive, about 22 kilometers, even more. And it's very nice between the mountains, and clear your mind and think better to have the intraoperative consideration. The patient need a very good pre-medication, and need to think about the fluid management and type and volume of those fluids, what you're going to give, and the stroke volume monitoring, adequate perfusion pressure, and the microcirculation as well. And what monitoring are you going to use to those patients? And think about the pharmacology as well for those patients. Pre-medication, and these are drugs we give before surgery or before anesthesia. And basically, if you are thinking about aspiration prophylaxis, this patient has gastroparesis, especially if he's diabetic as well, it is synergistic. So gastroparesis from uremia, gastroparesis from diabetes, and the delaying gastric emptying, those patients are liable for aspiration pneumonia. And if you give them sodium citrate, this patient might be an aluminum binder antacid, so you may lead to toxicity. And think about anxiolytic and short-acting like midazolam, or if you are thinking about opioid, you may think about fentanyl, which is very safe in those patients. As regards the fluid, no ideal fluid. If I know one, I will give it. And basically, before think about the fluid, check at the patient. Is he dry weight? What does the dry weight means? I didn't know what is the dry weight till I started to prepare to this patient, to this presentation, to be honest. Dry weight is the lowest tolerated post-dialysis weight achieved with minimal side effect. You need a calculator for the intracellular and extracellular fluid to get a dry weight. And if you get a patient dialysis to the degree of the dry weight, you expect intradialytic hypotension and hypovolemia, and it might be due to sympathetic neuropathy, underlying cardiac disease like cardiomyopathy, and it might be there is no gold standard measurements of the dry weight. Sorry. Again, no ideal fluid for those patients, but the most important is to avoid any potassium-containing fluid. Basically, we give sodium 0.9% normal saline, but the more sodium chloride, you result in hyperchloremic acidosis and poor outcome. Some people try to give hetastarch as a volume expander, but sometimes it results in renal insufficiency. And Citanova studied the high molecular weight Hess for volume expansion in brain dead donor lead to renal insufficiency. Some people using albumin, but just remember again, it is not without side effect. And the blood, usually we give blood if the hemoglobin is below 7 grams per deciliter. Again, if you give fluid, practically, if I have a renal failure patient, I start with the least amount of fluid, like a bottle of 500 ml, to avoid any accidental overload and pulmonary edema. Patient with congestive heart failure, you have to be judicious amount of fluid given to avoid any mortality or any morbidity for those patients. And the hemodialysis, the patient, the day before surgery to achieve eulemic, those patients usually comes after hemodialysis 24 hours before surgery. We should be cautious against hypotension at the induction of the anesthesia if those patients are dialyzed the day of surgery or the day before surgery. Again, that's the study of the hydroxyethyl starch in the brain dead donor, and they found that those patients had impaired kidney function in the recipient. And they found that in 52 patients, they have received hydroxyl starch before during surgery, and they found that that suggests hydroxyl starch used as a plasma volume expander in the brain dead donor impaired immediate renal function of the kidney in transplanted patient. Stroke volume monitoring, a hypovolemia with subsequent tissue hyperperfusion might occur during surgery, especially if there is high risk surgery. And the hypovolemia can remain undetected and may lead to post-operative complication, including organ dysfunction, especially the kidney. We don't want to do any harm or any more harm to the kidney of those patients. And the monitoring and the management lead to improvement the outcome of those patients. So hemodynamic monitoring, basically we use the basic monitoring, but just to remember again, even we have to be very cautious as regard the blood pressure cuff. Usually the IV usually go to the right side and the blood pressure goes to the left side. And those patients, they have the fistula on the left side, so we should avoid that. And even more vascular patient, they might have below amputation, and situation in this situation, it might be difficult. You may go for arterial line. So advanced monitoring, catheter-based monitoring, like blood pressure, central line, pulmonary artery catheter, use whatever you can use to improve the outcome, but be reasonable for those patients. If you wanted to monitor the cardiac output, use the pulse pressure variation, stroke volume variation, and saturated venous oxygen, and maybe the cardiac index. There's loads of technology, loads of monitor to improve the outcome, but be sensible, and every patient should be individualized. And sometimes we use goal-directed therapy to monitor the stroke volume for every patient just to improve the outcome. Our target is mainly adequate intravascular volume, adequate oxygen delivery, cardiac index to be normalized, and improve the pump function. And remember that we mentioned the dobutamine to improve the cardiac function, and inodilator or phosphodiesterase inhibitor to improve the right side function. Additional factors improve the tissue perfusion, like critical role of the blood viscosity and the nitric oxide release, and basically some patients, they have arteriolar vasoconstriction. So intraoperative recommendation for those patients, discontinue all nephrotoxic drugs, ensure volume status and the perfusion pressure, and consider functional hemodynamic monitoring, and monitor serum creatinine and urinary output, and avoid hyperglycemia. So a choice for anesthetic, basically it is entirely to the anesthetist and his evaluation. But in general, regional anesthesia is much more popular than general anesthesia, especially if the procedure allow us to do regional anesthesia like AV fistula. But we should remember that the pH affects the onset and duration of the local anesthetic. If the patient needs spinal or epidural, we go for it first as the first option. But we should remember that those patients, they have platelet dysfunction, anti-platelet therapy, or just to finish the heparin, we should check the INR and the platelet number. Regional anesthesia is very safe, and just remember that acidosis makes delayed onset, and the platelet number and function, and all of this stuff. So again, we use other nerve block or field block during general anesthesia, even to improve the pain therapy after post-operatively. Just to remember again, and as we mentioned, the patient usually they have either a central line for dialysis, or they have AV fistula in the left side, which makes our life difficult for IV insertion or central line monitoring. Just a little touch in the next few slides about pharmacology, because we are anesthetists, we are dealing with technology and pharmacology, and in pharmacology we should know about pharmacokinetic and pharmacodynamic of those drugs we use. But I will not go too much about that, but just even propofol is very safe because it is not metabolized by the kidney or not excreted by the kidney. Ketamine is very good for pain management, especially for patients in trauma. Dextromethorphan is safe inhalational agent like isoflurane and sevoflurane. Theoretically, sevoflurane, they say that it is nephrotoxic in prolonged exposure, but all of this in research. So inhalational anesthetic in general are very good. And opioid, basically morphine metabolites, either morphine 6-glucuronide or morphine 3-glucuronide. We like the morphine 6-glucuronide because it is analgesic, it has analgesic effect and good half-life. But the morphine 3-glucuronide is a neurotoxic, minimal analgesia. Fentanyl is safe. Remifentanil is cleared by plasmasterase, so it might show some increase in the half-life. However, it is very short-acting. The other part of the drugs we use always in those patients is neuromuscular blocker. And as we mentioned before, we should avoid succinylcholine as much as we can, especially if the serum potassium is higher than 5 or 5.5, because it is very well known that with succinylcholine, the serum potassium is increased by 0.5 at least. Renal metabolism of the drug versus hepatic metabolism, we use the drug metabolized by the liver. Usually, the ideal muscle relaxant is cisatracorium, which is 4 times potent as atracorium, but no histamine release and have Hoffman degradation. Nowadays, since we have the sugammadex, which can antagonize the rocronium in less than a minute, but the problem is the excretion is by the kidney. So this complex sugammadex rocronium is going to stay in circulation for a while. So neostigmine is a bit longer acting because it is cleared by the kidney. And if you have all of that, well done job, and go to Kiluf Mahar at the west point in Ireland, which is the Atlantic Ocean, and think about this patient where he is going after finishing the surgery, and is he going to the ward or high dependence unit or intensive care? What is the fluid status for this patient? What about the electrolyte imbalance? Take blood gas and check what is the lactate, what is the calcium, what is the blood sugar, and the post-operative pain management. If there is any expectation for post-operative cardiac risk factor, does this patient need post-operative assessment, especially the cardiac diagnosis, any post-operative cardiac complication? This patient will require regular hemodialysis or going to intensive care to require continuous dialysis. When I'm going to give the patient heparin or low molecular weight heparin, usually it is multidisciplinary approach, and we need to think about the pain control. Usually, paracetamol is safe. We avoid non-steroidal anti-inflammatory because they are one of the leading factor of renal failure. And by the way, here I remember when I was in Saudi Arabia, I have a patient who was renal failure, and his brother was visiting him. The patient himself donated his kidney to his brother. His brother was renal failure, and his brother was very well and surviving. The patient was in long-term non-steroidal anti-inflammatory with a single kidney. He developed renal failure, and he was waiting another transplantation for him. Local anesthetic infiltration is good, and we use it a lot for blocks or infiltration to improve the pain threshold here for those patients. Regional anesthesia, as we mentioned, is ideal for those patients as intraoperative and post-operative as well for pain control, and they decrease the thromboembolic manifestation. And if you don't have all of that, the option is BCA, which is very good and control patient pain. Back again, 75 years old man, end-stage renal disease, regular hemodialysis scheduled for AV fistula. He has dialysis through central catheter. So this patient comes for AV fistula. So pre-op assessment, if I'm going to give him a block or a brachial plexus block, I wait enough for this adductus to be cleared, 24 hours or 48 hours basically, and I plan for him to give him brachial plexus block. But just be cautious about the blood pressure monitoring as well. Avoid any manipulation on the left side, control his diabetes, and usually with brachial plexus block go very well. Back again to another case, pre-op assessment is mandatory to have a very good outcome, and think forward for those patients may need sedation during surgery, and try to avoid general anesthetic because it is another alternative factor if the local anesthetic fail to work. Take home message today from my presentation. Kidney disease is not only the kidney, it affects everywhere in the body, affecting from the brain, encephalopathy affecting the heart, cardiomyopathy affecting the lung by dyspnea, affecting the blood by anemia, affecting the gastrointestinal by gastroparesis, the hemoptysis, hematemesis, and everywhere. Peri-operative dialysis detail should be well known, and the 24-hour dialysis heparin-free before surgery improved outcome. Hemodialysis via the catheter should not be used for the anesthesia. So the catheter, we try to avoid it because basically they have some heparin, and it should be clean and should avoid any infection. Avoid left hand as much as you can. Avoid hyperkalemia. If the patient with serum potassium, should refer him to have a better serum potassium. Bleeding dialysis should be anticipated, and those patients might have some blood cross-matching before surgery, and be cautious about the fluid management. And the invasive monitoring should be considered for moderate to high risk patients to have a very good post-operative outcome. And thank you very much for having me tonight, and thank you much for listening to this long presentation.
Thank you very much, Dr. Saad, for this sincere efforts for discussing the issue of preoperative handling in patients with chronic kidney disease. The most important words you mentioned is a multidisciplinary care approach. And for the anesthetist to know everything about the patient, details, history, examination, laboratory abnormalities, and to anticipate problems in CKD, because CKD means cardiovascular disease in general, because this is one of the non-traditional risk factors for the cardiovascular disease. Just one point regarding the drugs that you mentioned. Glucophage is not used for patients on dialysis because of the risk of lactic acidosis and the problems of using this drug. And our recommendations is to stop it if GFR is less than 30 milliliter per minute. However, some seniors and some experts used these drugs, but for small dose for patients with advanced CKD and even on dialysis. But we don't use 850 milligram twice a day in a patient on this stage on dialysis. So we have many points for discussion, but I prefer to leave the mic to Professor Saad Khamis to start the discussion. And I think we have Professor Said with us. and I'd like to hear from him his valuable comments. Dr. Said. Professor Saad Khamis.
Thank you, Professor Hussein. You hear me, sir?
Yes, yes, yes. Go ahead, please.
Okay. Thanks, Professor Saad, for this elegant presentation. Actually, it was very comprehensive. Actually, I have a few comments and two questions. One comment is regarding the bethidine or meperidine. As you said, we try to avoid it as much as we can because it is convulsogenic with CNS toxicity, especially if we give it in the full dose. And if it is mandatory to give, we should adjust the dose according to the creatinine clearance. Second point is regarding the DDAVB in the bleeding. It is used usually in the minor procedures like dental extraction and so on. If there is a bleeding in our patient, I mean CKD patient, as you mentioned. But we should put in mind that tachyphylaxis is there. That means the rapidly acquired tolerance can occur because of the depletion of von Willebrand factor. And also, we should keep eye on the blood pressure because it can affect the blood pressure. My question, Professor Saad, regarding the when we are consulted as a nephrologist, say in the surgical ward from our colleague, the surgeon, to see a patient with, say, creatinine 2 or 3, we will undergo, for example, cholecystectomy. And they said, please inform us if he is fit for surgery or not. Actually, our reply is just to tell the precautions, to assess the patient, to request some important investigation, as you mentioned. And I think by the end, we say that the decision of fitness or not, it is to the anesthetist. Am I wrong or correct? That's number one. Number two, when there is a severe hyperkalemia, intraoperative in a major operation like cardiac operation and so on, do you have any experience regarding the intraoperative dialysis for this patient? And thank you so much.
Thank you very much for, first of all, again, for having me tonight. And thank you very much for these two valuable questions. Basically, the decision to put the patient sleep or not is entirely to the anesthetist who is going to look after this patient. As Prof. Hussein said, that it is multidisciplinary team. We consult everybody, we consult each other, and we have agreement at the end to put this patient sleep or not. We do all the investigation. We have a plan for this patient. We have to involve the patient as well in the decision if you're going to anesthesia or not, and inform the patient about the expected risk factor. Like, for example, when I mentioned the cardiac risk factor, we give them points. If the patient has renal impairment, he has 2 points. If the patient is diabetic, he has 2 points. If the patient has congestive heart failure, it's 2 points. If the patient has myocardial ischemia before, he's another something like that. And we get a score, and then we tell the patient that you have a very operative chance to develop acute renal impairment, very operative cardiac risk factor, and all of this the patient should know and accept all of this risk factor to go. The problem actually facing us is the emergency situation. And we have no time to discuss, even with our colleagues, if the patient having, like, for example, acute abdomen, diverticulitis, abdominal sepsis, and the patient has already renal impairment, cardiac dysfunction, cardiomyopathy, diabetes, and all of this coming for emergency, we stratify the risk and we go for surgery. But once again, the decision after all of this multidisciplinary meeting, the decision to put the patient to sleep or not, it is entirely for the anesthetist. And like, as you mentioned, we send the patient for cardiology review, and the cardiologist come, and this patient can go for anesthesia. It's not logic, to be honest with you, because the cardiologist will not take the stress for the anesthesia, will not decide which monitor is going to use, will not decide which fluid are going to use, when we are going to transfuse this patient. As regard the second question, I left cardiac anesthesia almost 10 years now, but as long as I know, there is a lot of technology in improving now intraoperatively to do filtration even on cardiopulmonary bypass. They can do a filter for potassium, they can do filter for cytokine, because I know potassium, cold potassium solution is very important for stopping the heart during cardiac surgery.
Thank you very much, Professor Saad, for these 2 points. I should declare that fitness is an anesthesia term. So I built, from my specialty, I calculate the risk from the nephrology point of view, and the cardiology the same. So the patient is evaluated by specialties, and the decision of fitness, it is 100% anesthesia after all these multidisciplinary consultation. I agree with this point. Since a couple of months, we have a very nice presentation delivered by our colleague, Professor Khalid Mahmoud, about ECMO and CRRT in cardiac surgery. And so I think this issue is advancing nowadays in the cardiovascular surgery. But I would like to stress upon, if we are thinking of potassium, as Dr. Saad showed, potassium less than 5.5, it should be the potassium that we accept. So if we have patient on dialysis, because this is one of the questions in the chat, if the patient is treated with hemodialysis as regular dialysis patient, and then we have surgery or operation, the idea is to do surgery, dialysis 24 hours before the operation. The patient should be in well fluid balance, electrolyte balance, no acidosis, everything is fine. With the only exception is renal transplantation. If we have a patient candidate for transplantation, we may think of not doing the dialysis the day before surgery, except if there is critical indication for dialysis, because we are expecting in live donor kidney transplantation that the patient will the surgery will be followed by immediate diuresis. And if we make dehydration, if we do aggressive ultrafiltration before operation, this may delay diuresis. So we are not, from the wisdom point of view, we don't do the dialysis routine for candidates of renal transplantation, especially for live donor kidney transplantation. I would like to add a point before giving the mic to Professor Riyad Saeed, and I would like to hear from Dr. Saad his perspective about this point, because I always say to my colleagues in anesthesia and surgery, please don't postpone the surgery or operation to patients with end-stage kidney disease or on dialysis patients, because if you postpone it to the last shift of operation and the patient continue fasting, these patients are in risk of fasting-induced hyperkalemia. Because, as you know, Dr. Saeed, the fasting may induce, fasting in a normal person will reduce and switch off insulin release. If I have perfect kidney and then fasting reduces insulin, and then there is some insulin is reduced, there will be some redistributional increase of potassium. If the kidney is perfect, it will get rid of any potassium, no problem. But for patients with end-stage kidney disease, if I prolong their fasting with reduction of insulin, redistribution hyperkalemia may even be fatal in some of them. This is one of the factors that I advise against fasting, for example, Ramadan, for those patients with end-stage on dialysis. Dr. Saad, if you have patient with CKD, advanced CKD, or on dialysis, what do you do? Do you still recommend fasting for many hours, or there is no need for this extensive fasting?
Well, we have completely changed our fasting protocol. Usually, if they are elective surgery, we let them to be fasting only 6 hours before surgery and allow them for clear water up to 2 hours only before surgery. So just it's better to be hydrated, even because they have their fluid restriction for renal impairment or renal failure, but at least they are a bit hydrated rather than to be fully dehydrated like normal patient.
So there's no need and no benefit of absolute fasting for many hours before surgery.
For the food particle,
Yes.
6 hours.
Yes.
That's the protocol. But for fluid, up to 2 hours only.
And this is what we do. If the patient on dialysis is, the operation will be done afternoon, I give him some, even if I am afraid of food, I give him glucose to avoid hypoglycemia, because renal failure is a state of hypoglycemia risk. I would like to hear from Professor Riyad Saeed. He's one of the legends of nephrology in Arab world, and he's one of the senior professors in Jordan. Professor Riyad.
الو
الو
مساء الخير.
مساء النور، اهلا وسهلا، اتفضل يا باشا.
الله يخليك. ازيك يا سعد. Dr. Saad, I think this is one of the best talks that I heard about pre-operative evaluation, intraoperative and post-operative. It's a good talk in renal physiology and physiology as a whole, which is that part of anesthesia. Now I have several comments. Just I'd like to start from what you mentioned, or the question posed about intraoperative dialysis for patients with potential renal failure, hyperkalemia. Yes, I think we do have the facility to go into the OR and help with this, and we have our capabilities to do dialysis intraoperatively. That's easy to be done. I'd like to make a distinction between elective surgery, when we have every time with us, all the people around, cardiologist, surgeon, anesthesia, and the most important thing I think I'd like to have my colleagues, the anesthesia, to come and see the patient, not really in the OR, to come down and see the patient, talk to the patient, as you mentioned. It makes a lot of things easy for everybody. And the final decision for suitability or not is the anesthesia work. So that's the elective thing I think is done. The practice for emergency situation. Now, what you do when you have a patient will come for fracture, trauma, and he needs surgery and he's on Plavix. What are you going to do?
Basically, we know the half-life of those drugs are prolonged, especially in renal failure. And because factor 10A is prolonged as well. So the pattern of those antiplatelet function is completely disturbed in renal failure. But we have our local and national and international guidelines for those patients. Those, for example, the hip fracture should not be delayed more than 24 hours to be fixed, because the complication for delaying those patients is much more than doing them earlier. So we take the risk and we do them under general anesthesia, because if they are capable to have general anesthetic. But if they have no other option, we might have to wait another 24 hours or 48 hours. If they are, Plavix usually 5 days. The minimum days are 5 days to 7 days to have to be off Plavix, because I know that a lot of people quoting this figure. But for some drugs like Alicus 24 hours, 48 hours, Xalerto 48 hours, some other different days and different time. But the rule of thumb, hip fracture should not be delayed more than 24 to 48 hours. If they are not candidate for regional anesthesia, we have to go ahead, we give them general anesthetic.
Well, I think the custom really with Plavix, we can hopefully reverse some of its effect by giving high dose steroid, up to 1 gram solimedrol. There is a nice people really we talked about from George Washington in the United States, and came to visit us, and that's really what they are doing. In fact, we did this for several patients who really want on an emergency situation and they are on Plavix. Dr. Hussein, the group, what do you think about this?
So I agree with all what you mentioned, Dr. Riyad. There is a complete difference between elective and urgent surgery.
That's true.
if we are dealing with septic shock or the patient with perforated viscous or whatever,
that's
the rupture dissecting aortic aneurysm, I'm not going to here to list. So yes, I calculate the risk, I prepare fresh blood transfusion and everything, and go ahead for surgery because there is no rules for emergent surgery to be done. But if I am in elective way, I stop Plavix for 7 days, 5 days, aspirin, and even the dogmas. And you reminded me by one of my talks here at Urology and Nephrology Center a couple of years ago about peri-operative handling of antiplatelets, because I discussed with the urologist that it's better to calculate the risk, it's better to respect the patient comorbidities, cardiovascular, cardiac, coronary, etc. And then to sit together with the cardiologist, with the anesthetist, to evaluate should we discontinue antiplatelet altogether in this patient or to go to surgery. From urology point of view, calculate your risk. This is what I mentioned to them. This is a bloody surgery? There will be a risk of bleeding. And from the cardiology point of view, is a condition permitting discontinuation? Because if I can prepare blood for blood transfusion and be meticulous and doing a gentle technique, and instead of stopping, for example, aspirin, and the patient may die from coronary event. So it is, at the end of the day, is calculation of the risk benefit. And in emergency, I go ahead just sparing the blood, and that's what we do.
My second comment.
Yeah.
Dr. Saad, yes. Please.
I have a little comment here, if you don't mind me. We agreed as regard the elective surgery should be deferred till optimization of the patient condition, because the patient in this situation, he does not have only kidney problem. He has kidney, diabetes, heart, and everything should be optimized in the right way. As I mentioned, if the patient has Plavix or antiplatelet, and if he needs for surgery, and the worst scenario, he might bleed, and we put in our mind that he might need platelet and the blood transfusion. So that is a situation we might consider platelet, but for some patient, if they have, for example, a stent, and we should calculate the risk very well. If they give them platelet, it might lead to be, this patient might be thrombotic and lead to peri-operative cardiac ischemia as well as a complication of platelet dysfunction. So, that is all against, like risk assessment for to give platelet or to give blood, to hold the Plavix, to give that, to continue, to go for surgery or to hold the surgery is always multidisciplinary team again, and all of them should be according to the patient benefit.
It's multidisciplinary, multi-speciality discussion, and individualization for each patient in itself. Exactly. Because the dogma, and I like your statement that you have guidelines for and the pathway for each case, because I think the aspirin approach is completely different nowadays than 10 years ago.
Exactly.
So to the extent that if the patient will be subjected to brain surgery, for example, aspirin should be discontinued, because any bleeding in this area will be catastrophic. So I should categorize the risk according to the patient characteristics, operation characteristics, comorbidities, and each patient has his or her rules. I think this is the point, Dr. Riyad.
Okay, second point, please. The practice that we come, our anesthesia colleagues will come see the patient overnight, during the night, and then put the order NPO, nothing by mouth, and that's a classic order usually placed. We are not against that. We can hydrate our patient. We can do everything overnight to avoid what you mentioned as hypotensive episode during induction of anesthesia. My point is, medication that usually the patient is taking, especially blood pressure medication, usually the staff, they will stop all medication. By the time the patient is ready to go to the OR, we receive a call from the OR, well, your patient is really high blood pressure, having high blood pressure, we cannot really operate on him, now we'd like to cancel the surgery. The most really distressing thing for a patient is to cancel his surgery for himself, for the family, for everybody. So my message from this, please, when we say PO, please accept for medication. There is nothing wrong by giving the patient a couple of tablets in the morning, even with a few cc's of water to drink with that. That will not really break his NPO. So what I'll do, I'll say except for, please give the patient his medication to avoid cancellation. Do you have any objection, Dr. Saad, for this?
Not at all, and totally in agreement with all what you said, sir. But the only issue as well we have now, when I came to my hospital, I founded and I developed the pre-operative assessment clinic. As you mentioned that even more than seeing the patient during night time, after the patient coming from home, admitting to the hospital in the night before surgery, and the anesthetist come to visit him the night before surgery, oh my God, you are not fit for surgery tomorrow. And I believe that very stressful for the patient, and spending few nights in the hospital doing some investigation to be ready for the surgery next week. We have now the pre-operative assessment clinic, and the patient come on time and to be seen by the anesthesiologist as a clinic, like what you see your patient is renal clinic in the renal clinic, and we decide where this patient would need. Need an echocardiography, need to visit the nephrologist, need to see the cardiologist, need to see the chest X-ray, or whatever we need to do, and the all pre-operative investigation. So the patient would have to come the day of surgery from home, just coming on foot, you know, or even driving, coming to the patient to the hospital in the morning, 7 o'clock in the morning, sitting in the waiting area, just all the instruction to be given to the patient, written instruction, and the patient very well understanding all the instruction, especially to identify which medication would take in the morning, which medication would omit in the morning, how many hours he's going to be fasting, fasting policy, fluid, and some patients as well, we give them a high carbohydrate diet before the night before surgery, and may have some drink in the morning to improve the outcome.
If you allow me, Dr. Riyad, I would like to add here some points about medications and their discontinuation.
Pulse steroid therapy, yes.
Because there is a question on the chat, immune suppression to be stopped for how many days before surgery? We don't
stop it.
Because they are necessary. So the rule is the necessity and the safety. So if we think of immune suppression should be given, even if we give immune suppression on the day before, in the morning of the operation by little amount of water, oral, or to change some of medication to intravenous, like prednisolone to solomedrol. Regarding antihypertensive treatment, yes, hypertension control is important, because if we leave the patient without blood pressure medication, then the patient will be hypertensive. But to put in mind, if the blood pressure is stable, we write the instructions and educate the patient to stop RAS blockade, ACE inhibitor, and ARBs in the 24 hours before surgery, because if these drugs may be troublesome for patient prone to hypovolemia or shock or bleeding in the surgery, and they were treated by RAS blockade, this may increase the insult of the kidney. This is why we stop them, except if the blood pressure is high and stable, then we should inform the anesthetist, take care the patient on ACE inhibitor or ARBs, and these drugs may be to be very cautious with this patient regarding any hypovolemia or bleeding. If the patient is treated with drugs that shouldn't be discontinued or associated with rebound tachycardia or rebound hypertension or hypotension, we should be careful about every drug. So the necessity and safety are the rule that govern the continuation or discontinuation. For example, in diabetic management, we should stop, for example, sodium glucose cotransporter 2 inhibitors before surgery, and not to be resumed except if the patient eat well and become stable, because of the risk of euglycemic ketoacidosis in these patients if they are prone to prolonged fasting. So for each drug, necessity and safety are the rule for continuation or discontinuation. Dr. Riyad, I'm sorry for
Agree.
this interruption.
No. I think that's exactly perfect. Nothing better than a good history, medication review, and that's really a safety valve for everybody. Thank you, really. I appreciate the talk.
Thank you.
Thank you very much, Dr. Riyad. And I think Dr. Said will take the question in the chat. Do you see the chat, Dr. Said? So we have here question from safety perspectives. Could you elaborate on escalation of painkillers post-operative in CKD and in stage kidney disease? Dr. Saad.
Yeah, basically we use multimodal analgesia, and we start from the weakest to the strongest, and we try to avoid drugs with nephrotoxic and neurotoxic drugs, like we mentioned, the mibridine or bethidine has a neurotoxic effect. We try to use the drug with a wide safety margin, like morphine. We can say that morphine, or maybe oxynorm is better than for nausea and vomiting. We can use BCA for those patients, but we depend a lot on the regional anesthesia and the peripheral nerve block and local infiltration to avoid systemic drug. So the most important drug to avoid is non-steroidal anti-inflammatory, which is nephrotoxic and try and do much more harm to the kidney itself. So I would like to avoid developing of acute on top of chronic renal failure. So basically, we start with paracetamol, and we use local anesthetic a lot, regional anesthesia. As we mentioned, morphine has advantage. It is metabolized to morphine 6-glucuronide, and which has a further analgesic effect. But morphine 3-glucuronide has a toxic effect. So we would like to make it multimodal analgesia rather than one mode of analgesia. We have adjuvant drugs like dexamethasone and clonidine as well, which are very safe in renal failure.
Do you use any more epidural analgesia?
Of course, yes, it's very safe and it's very good for those patients, provided, as we mentioned before, drugs like antiplatelet or platelet function are normal, or if there is no contraindication to epidural, it is very good for analgesia, and even some surgery are carried solely under epidural anesthesia.
But I think the dose should be optimized, because excessive epidural analgesia may be problematic associated with vasodilatory shock. And I witnessed a case, severe hypotension after epidural analgesia, and we give the patient many drugs, including noradrenaline and even phenylephrine, to raise blood pressure from severe vasodilatation. Do you like to comment on this point, Dr. Saad?
Certainly, as we mentioned before, that every patient should be individualized. And back again, when we receive the patient, we would like to talk our nephrologist colleague to understand about the dialysis, and if this patient, how much dialysis he had, is he dry weight, or how much fluid he has, when he has been dialyzed, and what is the balance of this, is he negative balance or positive balance or even balance. That's very important. All are important precautions. And for every single patient, it should be individualized, and we should use all invasive monitoring to monitor the blood pressure, even beat by beat during the procedure, which facilitates us to act immediately to avoid any hemodynamic disturbance for those patients. Certainly, epidural is very good, and the approach to the epidural should be very cautiously to avoid any hypotension. The anesthetist usually prepared and they got ready with vasopressors like phenylephrine, like noradrenaline, but noradrenaline should be given by central line. So it is multiple approach to avoid. So back again, we should understand the pathophysiology. We should understand the basic stuff about those patients, like what I mentioned in the beginning of my presentation, to avoid and to optimize my intraoperative technique and to reach the best post-operative outcome.
Still, you use central venous pressure monitoring for patients, because we stopped this policy because it was our routine here from the anesthetic point of view for renal transplant recipients to monitor central venous pressure. Nowadays, they stopped this technique.
Well, in major surgery, we use central line for many reasons. Number one, to give drugs. Number two, to give fluids. And number three, for a vascular access. And because those patients either dehydrated, they are difficult to get a peripheral IV, or overhydrated, they are edematous. And at the same time, we have a limited access because we avoid the left side for the arm. You know, the left arm completely avoided either for intra-arterial line or IV line. So sometimes the venous access would be the only way. But yes, we use it for central line monitoring to show us the filling pressure. At least it is not like transesophageal Doppler or not like transesophageal echo or whatever, but it's still valid as a monitor option.
What is transfusion trigger point for chronic renal failure patients?
As I mentioned before, we sit around from 7 to 8 hemoglobin, because those patients are very well tolerating anemia because the oxygen dissociation curve. But the target of 10 is very good. If you can reach target of 10 by EPO or by iron infusion, that's very well. If I can reach 9 or 10, that's very good. But if the patient below 7, I start immediately transfusion.
So below 7, it is needed, especially in surgery, but to be very careful in patients who's on dialysis, who will be prepared for transplantation, to avoid sensitization. So, but below 7, I think it is risky to do surgery for below 7.
Absolutely.
But for emergency, to be done with the presence of blood. Yes. For how many days we should hold the immune suppression? No hold for immune suppressive drugs, because it may be problematic in transplantation. For example, we give the immune suppressive. We don't hold. There is no days. We should give immune suppression because this may be associated with many problems like rejection, etc. Even in patients who are treated for long period on corticosteroids, we may even increase the dose of steroid to face the stress, because after the years of steroid, the native suprarenal gland become lazy and doesn't respond to the stress by increasing the output of cortisol. So this is why we even give a little bit bigger doses of steroid. So we don't withhold the immune suppression. This is from our side.
That's right.
Usually these patients have chronic anemia. What is minimum allowable hemoglobin level for non-bloody operation? I think we answered this question. Elective operations. For elective operations, when you prefer that in the stage renal disease patients should undergo dialysis immediately before operation, yes. 1 day before, within 24 hours. We need the patient to be eovolemic, electrolytes perfect, potassium ideally to be less than 5 and not exceed 5.5. This is what we need, and no acidosis. All these are our advices for our patient, to do heparin-free dialysis 1 day before any surgery. But for transplantation, live donor kidney transplantation, we can postpone dialysis on the day before surgery, especially if the patient is not overloaded and no hyperkalemic, no acidosis. Dr. Saad, would you like to comment here?
That's actually, as back again, like what we all mentioned, we agreed about multidisciplinary team, about discussion between the managing team, like nephrologist, the surgeon, anesthetist, and even the cardiologist as well on board to participate in the management of this patient. Basically, the nephrologist and the anesthetist are the people who decide when this patient going for dialysis after surgery, because this patient might have massive operation. If he's going to dialysis, it depends on the fluid status, electrolyte status, acid status, and in the same time, he might need, if the major surgery, he might need heparin-free dialysis. That is completely entirely needs cooperation between the team. It is a teamwork, not only one person to decide who is this patient going to have.
I think this is the best answer, individualization and respecting the characteristic of our patients. If the patient is anuric, we cannot be liberal in giving fluids. If the patient is pleuric, can we give fluid? If there is the use of even isotonic saline should be careful, because excessive isotonic saline may lead to acidosis, as elegantly mentioned by Dr. Saad.
Thank you.
Dr. Said, do you like to have any comment here? Dr. Saad Khamis. It seems that he is using the mobile and the computer. Okay, okay. Dr. Saad, I think it is very nice. Yes, Dr. Said.
You hear me now?
Yes, Dr. Said, go ahead, please, if you have any points to add.
No, just there are some questions in the chat regarding the tramadol and fentanyl. I think fentanyl, Dr. Saad already mentioned. Tramadol, I don't know. You can mention, please.
It is very weak analgesia, even it is opiate. We don't use it much in my practice, especially in my institution, in the perioperative situation. We mainly use fentanyl, morphine, remifentanil. Those drugs that they have the well-known effect. Might be clonidine and dexamethasone are newly introduced now to the clinical practice, but tramadol is very weak for both intraoperative and post-operative care.
And the abuse of tramadol is common and may be associated with convulsion. And Dr. Ahmed Abab here from Mansoura University reported a publication about tramadol even in dialysis patients. And from Ain Shams University experience, there was a report about the tramadol used by healthcare workers and by dialysis patients. And so I don't like this drug, and to educate patients and persons about its hazards and to avoid the abusing of this medication. Dr. Said Khamis.
There is another question from Dr. Khalid Abu Zaid. Incidence of life-threatening hypotension attacks after bilateral nephrectomy. Is it there?
I think the question is to us, not to Dr. Saad. There is, if the case is huge polycystic kidney, and because there is, I am from the school that doesn't advocate bilateral nephrectomy in polycystic kidney disease in preparation to transplantation. But there is another school, even simultaneous bilateral nephrectomy and transplantation. Because we confronted with a case, severe hypotension after bilateral nephrectomy for huge kidneys, because they make imbalance of the fluid and the venous, and so this is our school. Even if we decide to do nephrectomy, bilateral nephrectomy, huge kidney, we should be careful in monitoring the patient well.
There is another question from Dr. Ahmed Aziz. Is it mandatory to use heparin-free dialysis 24 hours before operation? It should be, it must be heparin-free or not? Yes.
The half-life of regular heparin is not so much, but we learn it from the practice. If the patient is dialyzed before surgery and coming to the ward, the surgeon usually suffer from bleeding and oozing. To be careful, if I can run the dialysis without heparin, why I give heparin for patient who will be exposed to surgery? I can give fluids and to add the amount of fluid to ultrafiltration. That's it.
Yeah.
Dr. Saad, would you like to add or to comment on this point?
Certainly, the most important before elective surgery, the patient would have dialysis. And
Yes.
that's the most beneficial for the patient. If we can, as Prof. Hussein mentioned, that if we can do the patient dialysis without heparin, it is another point or another bonus for the post-operative, intraoperative, and the post-operative care. Certainly, it will help me to do any nerve block or any epidural or intrathecal injection, and certainly it will minimize the even potential or even the fear of bleeding and the blood transfusion. At least it will make the anesthetist surgeon working in a better, quiet environment.
Because the half-life of heparin is prolonged, even if it is conventional heparin, prolonged in the presence of renal failure. We need dialysis because hemodialysis improves platelet function. And we don't like heparin because it will lead to bleeding diathesis. So this is what we do. And complementary statement about anemia management, why we don't like anemia, because anemia, for platelet to function well, they need RBCs, red cell volume, because from the rheological properties of the blood, RBCs like the supporter of the platelet to function. If the patient is anemic, there will be platelet dysfunction by anemia, and anemia is a risk for bleeding. This is why we don't like. But at the same moment, we should be cautious, and if we have ample of time to give ESA therapy, iron, and instead of blood transfusion, because we are afraid of sensitization of our patient. I think doing the transplantation for a child is a stress for the surgeon and the anesthetist. And guiding the fluid status for pediatric patient, I think this needs an expert anesthetist, how to monitor the blood pressure and deal with the blood pressure according to the findings and monitoring the profile. Do you like to comment on this point, Dr. Saad?
Certainly, in pediatric anesthesia per se, even before transplantation, pediatric anesthesia is a special entity of the anesthesia, and it has its own training and own specification, because the stress for working in pediatric is around 10 times working with adult. Calculation, the dosage, pre-operative assessment, post-operative care, intraoperative monitoring, everything is completely different in pediatric than the adult. If you go down to the transplant issue, it is completely different.
It will be more risky because we put adult kidney in small child. Adult kidney will suck all the blood. So this is the stress on the anesthetist to optimize the fluid status. Otherwise, there will be a problem because there will be delayed diuresis. So blood pressure, blood volume, everything should be optimized. Yes, Dr. Said.
Last question, because now we are 2 hours.
Okay.
Put a lot
the last question. Yes.
Last question from Dr. Masoud Khairi in the chat. What about new oral anticoagulant? I think Professor Saad told, but
yes,
okay.
Yes.
In urgent and elective surgery.
He mentioned, Dr. Saad mentioned the elegant, the Elicas and the Elicas and the Relto, and all these are direct oral anticoagulant, and they are clearly shown in the European guidelines for pre-operative handling of new oral anticoagulant. According to the risk stratification of surgery, there is the interval, this drug should be discontinued before. And if the patient in urgent need of anticoagulation, there is a bridging school. Dr. Saad, do you like to add any point here? This is the last question.
Usually we, in my pre-operative assessment clinic, we have the protocol and the guidelines, and we have the scores for chat scores, and we assess the patient weight and age and the risk factor, like if the patient is on metallic valve or whatever, peripheral vascular disease, pulmonary embolism or whatever, and we put him the score, and we would like to calculate how much he is going for bridging or no bridging. Usually we give them bridging low molecular weight heparin for at least 5 days before surgery. We have to stop the oral anticoagulant, either warfarin or Elicas or clopidogrel, according to the preset time for each drug. because, for example, Blavix is 5 to 7 days, and I believe this time would be prolonged in renal failure patient. Warfarin is 5 days, but it is not 5 days for renal patient because the half-life as well is going to be prolonged. But overall, we bridge those patients, and finally, we check the INR in the day of surgery.
INR is helpful for warfarin, but it is not 100% helpful in others. Direct oral anticoagulant, and for direct oral anticoagulant, for example, dabigatran, there is molecular antibody to reverse its toxicity, and for factor 10, there is a specific drug which is very, very, very expensive. So I think I agree with Dr. Saad Khamis. 2 hours is very exhaustive to our beloved Dr. Saad Mahdy. It is our honor and pleasure, and on the behalf of the Egyptian Society of Nephrology and Transplantation, CME, this is just a symbol of appreciation to Dr. Saad Mahdy for recognizing his distinguished contribution in delivering this presentation, Peri-operative Management of Patients with Renal Dysfunction. And I agree 100% with our Professor Riyad Saeed. This is one of the very nice presentation, a lot of details about the orientation of anesthetist, about the physiology and the lab and the etc. So I think if we say one word from this lecture is to respect other specialties, to work together in multidisciplinary team. And we agree 100% the person who can say the patient is fit or unfit is the person who will do anesthesia for the patient. So thank you very much, Professor Dr. Saad Mahdy, for this very nice presentation. And we are sorry for exhausting you in the questions, but we are appreciating and also appreciate the presence of Professor Saad Khamis as moderator in this session. And Professor Saad Khamis, he is the man behind the invitation of Dr. Saad, because he told me that we have one of the Egyptian experts in Ireland, and he started his communication with Dr. Saad. So thank you very much, Dr. Saad. Thank you very much, Professor Saeed. I would like to thank all the attendees from nephrology, surgery, anesthesia, and special thanks to Professor Riyad Saeed for contributing to the valuable comments in this session. To this point, I should say thank you very much. And the last word is to Dr. Saad Mahdy. Do you like to say anything at the end of this session?
Well, at the end of this session, I am so grateful for inviting me to speak before this prestigious society, which I admire too much for being here tonight. And thank you very much, Professor Hussein, and thank you very much, Professor Saeed Khamis. And thank for all people and my colleagues, senior colleagues, to attend this seminar tonight. And good luck for everybody.
Thank you very much. Goodbye and have a nice night. Thank you and goodbye.
Thank you. Thank you.